Hello, everyone, and welcome to the Worldwide Fistula Fund's second programming webinar in our 2021 series. I'm Soja Orlowski, Executive Director, and in a moment, I'll be introducing our guest. Today's topic is developing physical therapy for fistula survivors. The Worldwide Fistula Fund believes in using holistic care in order to address childbirth injuries, and rehabilitative services are included in order to optimize outcomes for fistula survivors. Today, we're going to be talking specifically about developing a new program in Uganda at the Taraworty Women's Community Hospital. Joining us is Dr. Tracy Spitznagle. Dr. Spitznagle is a WFF board member and a professor of physical therapy at Washington University in St. Louis. Now, she has been mentoring the team in Uganda for over a year in helping them develop their programming in spite of the pandemic. Welcome, Dr. Spitznagle, and thank you so much for joining us today.
It's my honor to be here.
So I was wondering if you could start by giving our audience an idea of how you became involved with the Worldwide Fistula Fund and give us a little background on your expertise in physical therapy.
Yes, I actually learned about the Worldwide Fistula Fund when I was interviewing Dr. Lewis Wall back in 2001 when he came to Washington University in St. Louis. I'm a full professor there in physical therapy and specialized in pelvic health. At the time, Lewis was really interested in developing a professional relationship for my work in the United States, but also at that time he said he was developing, had plans to build a hospital in Niger and was hoping that I would be interested in traveling to Africa someday. I knew nothing about Africa or fistula at that time and had a lot of learning on my behalf. So you learn about pelvic health when you become board certified. Fistula is very rare in the United States, and so this was something that I spent the next couple of years learning about myself.
So I know you've provided physical therapy education and support at some of our other sites. So you've provided some support at the Danja Fistula Center to the physical therapists there over the years. But the most recent project you're working on is with the Taraworty team at the new hospital. So can you give me an idea of how you first started working with them?
As a board member and representative that was kind of the program chair for Uganda, I got asked go and do a site visit in 2019. And at that time, it was identified that there was really a strong need to develop a physical therapy relationship as the hospital was kind of putting their practices and policies together and getting the roof up all at the same time. So it was kind of something that came out of a needs assessment, looking at how could we improve the interdisciplinary care for the women at the center.
Okay. And so you've been working with them all through last year, right? So with the pandemic going on, how do you provide this mentoring and education to the team in Uganda?
Zoom. Let me tell you, it's been a godsend. Actually, in some ways, it was nice to have the time, the space over time, because classically, when I've gone in to any one center, I'm only there for a week or 10 days. And having mentoring sessions where I just carve out a couple hours in the morning, it's their evening, and can provide a small lecture, or we can review an article, or we can talk about the needs of the patient. It's just been a really wonderful and rich learning environment.
So you meet with them, you said like in mornings, like a couple of times a week or once a week or something like that?
I started out twice a week actually for a month, and then we went to once a week, and then we went to twice a month. Unfortunately, because of the new variant because of the pandemic that we're facing, the physical therapy mentoring is on hold because the program's on hold until they can get enough staff vaccinated and the program back up and running again. So it was going on about once a month, probably for the last 4 months until this big flare.
Okay. So you were teaching them, like, is it like classic lecture educator? Because you're a professor, obviously. Yeah. But also they were doing, they were starting to do hands-on care with patients, right? So how did you support them with that?
So it's a combination. The team that treats the women for pelvic health are both a trained physical therapist who was trained in Uganda, and then got training in Europe as well. We spent time outside of Uganda and did some training there. And then nurses that decided that they would be interested in learning more about rehabilitation for the women at the center. And so some of the education at the beginning was a very basic, how do you strengthen muscle? What's a safe way to walk someone? How do you get them out of bed safely? And then it moved into really listening to what the team had questions about and what issues and problems that were coming up with the cases. And so that's where we ended up kind of in this presentation format after we got through a lot of kind of the basic information. The pelvic health information in the United States is not part of entry-level education. It's considered specialty education above and beyond your doctorate. And so layering that on, how kind of showing them what they already know from an entry-level perspective can be applied to women with fistula. And then also empowering the nurses that they can learn the skills how to work with the patients, kind of like aides or techs.
Okay. So with a specialization in pelvic floor, that is the specialized training you need to treat fistula patients, correct?
Yeah, you need that. Plus, you need to understand mechanics of why fistula could occur and the state that the mother is likely to be in because she's postpartum. And everyone sometimes forgets about that piece, that all women all over the world could benefit from a physical therapist because they've got a change in their body, abdominal weakness, hip weakness, pelvic floor muscle weakness, which commonly comes with pain. At least 25% of all women who are pregnant have pain. So then you're on a birth that was arrested, and they now have compression injuries to the organs in the body, but also the vasculature and the nerves, which then drives muscle weakness. So the women commonly have gait problems where they have difficulty walking, and they need some kind of assistance with that. I would say everyone that they brought to mentoring has had pain, and so the pain issue has been quite obvious. And they commonly will have the other things that come with just being pregnant or delivering, incontinence that may be stress incontinence instead of just incontinence that's associated with the fistula itself. So it makes it complicated sometimes when you're seeing somebody pre-surgery or post-surgery. Post-surgery, we know the fistula is healed, but the incontinence might still be there. That can be so emotionally devastating for a woman who thought they were going to be cured with the surgery. So there's a component of care that you learn intuitively as you work with the patients because they need to be shown that sometimes the reason they have their symptoms, though it appears that it's devastating, can change with physical therapy. And that change then allows them to return home and feel more empowered. A lot of postpartum moms in the US have incontinence or pain, and they struggle and have a hard time with it. So it just makes sense. You layer on the fistula on top of that, and you need a little help from the whole team.
Would you say that most fistula patients need some sort of physical therapy?
Yes, I would say most fistula patients will need something because they were pregnant. So the abdominal muscle performance is off. And if they've had enough pressure in their pelvic region that the organs have had a problem, that is enough pressure that the pelvic floor has had a problem. And that's actually the window that I see in my clinical practice, is all of the prolonged labor cases that develop prolapse or pain, not necessarily going all the way to fistula. So in Uganda, when you get all the way to fistula, all of that has already happened, the damage that could be there that might be needed. So we haven't really talked about prolapse, but that is definitely something that comes hand in hand with birth, vaginal birth. And so, yes, many women need to see physical therapy after vaginal birth.
For individual therapy for a fistula patient, is there a typical, and I know it's very customized, so I probably shouldn't even use the word typical, but is there a certain number of days a week or a certain frequency of physical therapy, one-on-one treatment that a woman needs? And how long, or on average, are you thinking, have you noticed that the Uganda team is working with specific patients?
So they're trying to stay within a 2-week window after surgery, but a lot of times the women need care longer. And so they will hang on to them maybe a little bit longer than 2 weeks, but then ask them to come back for a follow-up like in a month. The women, once they're healed, really want to get home. And so I really tried to get them to think about, what can you do, what can you give them to do that they could take home with them to work on? So it could be that someone's having trouble with getting up off the ground, and so they're going to practice that skill while with them, try to get their hip strength stronger, and then give them some strategy for working on that when they're home, and then have them come back. So that follow-up could be done across like a 3 to 4 month time frame, where they just come back once a month after they've had like a 2-week intensive care. To me, that would be ideal, but it depends on how far away they're traveling and how expensive that can be. Paul, actually, who I'm working with, he floated the idea to me, is what about if they could start to do home visits? Now, this was before COVID really went up and flying, when we looked like everything was opening back up. But putting someone who has a physical therapy background on the trips where they're going out into the community and seeing how the survivor groups are doing, so they can do spot checks on people and see them in their environment and help them with specific skills in the environment. I thought that was a really beautiful idea. And it was like, well, we're going to have to save this one, because that sounds like the future. And right now, as you can see, we have no physical therapy going on at all. So
I'm going to back up a little bit to what you said about needing specialized training in pelvic floor. So, and you said it's not automatic even with training in the US.
Right.
So now if we're looking at Uganda, and you have to provide education that's not typical for the professionals in Uganda, when they're treating a patient, does the patient know that they need physical therapy? And do they understand that it can help them? And how do you address that if not?
That's a great question. I would say that you need the whole team supporting them in them understanding why they might need to see a physical therapist. The best person to start with is the surgeon, who recognizes that the service is valuable and it's needed, because the fistula itself is fixed, but they may still have what we call supportive impairments, where they need to learn how to use their muscles in a way that then helps reduce the pressure that would cause the problem that they're having. So the nurses need to understand about the profession and why it's beneficial. The doctors, any support staff that interacts with the patient, so that the patient can really kind of see how this rehabilitation professional is going to make a difference in something that feels so overwhelming to them.
So from your experience talking to the Uganda team that's implementing this PT program, have they told you like how easy or difficult it is to convince a patient they need physical therapy? Do most patients say, yep, or I don't really know what that is?
I would say that they've had a lot of experiences where the patients went because the doctor told them to, and they didn't want to be there. And when they started seeing results, they were telling everybody else in the room with them that it was important. You don't want to be here, but you're going to need it. It really makes a difference. Listen to what they're saying. It's just so important. So they're our best salespeople once they've gotten through the process.
Terrific. So you're turning
the I don't want to be here, the closed arm, lean back, you can't make me. And then when they interact with the staff and they learn that they have control over the things they have, they're so, like, they're our best salespeople.
Terrific. So you're turning fistula survivors into PT advocates as well, right?
Yes. Yes.
That's terrific. So tell me, kind of give us more specifics. I think a lot of us don't really know the nitty-gritty of PT, of identifying an issue and then figuring out how to address it. So if you could tell us a little bit about some of, like, you've already given us some background on what kinds of things happen as a result, but maybe tell us how you address them.
So a physical therapist is a movement scientist. So they look at how somebody moves. So the first couple of things that they do is just watch them walk, watch them bend over, see how they get in and out of bed, in and out of a chair. Then they go to look for very specific impairments, muscle weaknesses, that could then be treated in order to improve how they're doing those things. And so that is kind of the crux of it from the outside. And looking at, you know, if they're having trouble clearing their foot, is it just that they have, like, they need to work on strengthening, or do they need some kind of a device to help stabilize their foot so that their gait will be more stable?
So I'm gonna jump in here and say, what do you mean by clearing your foot? Like sticking it out of the way, or?
Good. Fistula patients commonly are, one of the things you can see is the foot drop. And so they have foot drop because the nerves that go from the spine all the way down, or from the knee all the way down, or from the hip all the way down, depending on where the compression injury might be. The muscles that are in the foot, the nerves have been damaged, and then they can't actually clear their foot as they're going through. And the reason I say the most obvious thing is that in traditional culture, women commonly don't have shorts on or walk around in pants. They have skirts on. And so you can't see their thighs and their legs and buttocks and see the atrophy of the muscle that goes all the way up the chain. And so it's sometimes a hidden, weaknesses are kind of hidden from the obvious eye, just because of the clothes that the women traditionally might wear. Leg weakness is very common after arrested birth. And so it's one of those, wow, this is something that PTs can easily help with. And it's easy to teach individuals to help with it as well.
So have you seen, like, give me an idea of how you've seen the PT team in Uganda grow and develop as you've worked with them? Like, give me an idea of how they started and kind of where you think they are now. And give us an idea of how many patients they're treating.
Well, they were very fearful when they first started of hurting somebody. And they kind of started with, you know, the first couple, like one a week. And the last I talked to them, they had treated, like, in the more than 30 patients was in the, not this past report of Alice's, but the one before. So they were seeing 30 to 40 patients potentially a month that were coming through. So it's grown exponentially in that regards. But I would say that in the beginning, they were a little shy to ask questions. They were a little, what about this? But they kind of gained a lot of confidence just in us having open dialogue through Zoom, open conversation. And so then it was almost like they couldn't wait to get on the call because they had so many questions that they had for me. So it's like the more they did, the more they wanted to double check to see if is this working? Is this right? This is what I'm thinking. Where before I felt like when we started, I was kind of like giving information, and now they're giving it back for me. And I can sit and listen and then ask a question at the end instead of the one that's kind of, you know, giving out all the information. So that part, the growth in that has just been wonderful.
So they're still sort of in their infancy in terms of developing their program, right? So I remember last year, Worldwide Fistula Fund gave a small grant to buy additional equipment or hire additional experts to help them on the ground as the on-site kind of trainer and stuff like that through the university. So what else do you think they need to get to the next level as they're expanding and as they're treating more patients? What do you think is needed next?
They really need some equipment to kind of objectively identify the impairments that they're finding so that they can show change. So for example, some simple things like a handheld dynamometer that would be able to produce force. You would put it on the muscle and then they would push against it and then they could record that and then show that change over time. They really could benefit from more skill assessment associated with pelvic health itself. So that's the one thing that's hard to teach in a Zoom format. So I would really love to be able to eventually go in, do needs assessment, and then teach a very specific manual skill related to internal pelvic exams. Let's see, I had a huge laundry list of things at one time. Sensory detectors are important. So SIMS monofilaments so that we can check to see how the sensation is. Gait belts so that they can safely get patients that are really debilitated up and walking. They really need assistive devices, walkers, canes, crutches, that they can not only have while they're in the hospital, but that they may have to issue to someone so that they can go back out into their community. So that's just kind of a few things that come to mind, but I know there's lots more.
And I remember from when you were working with the physical therapist at Danja Fistula Center, you were talking about how important continuing education is. So after they start getting this program going and past the launch year and more going on, do you see a need for them to continue to train with new concepts and do you see your mentorship role really ever ending, I guess, is what I'm wondering? Or do you see it as a continuous thing as they grow?
I think young clinicians need mentoring, period. So that's just philosophically where I come from. But at the same time, when you're working in such a rare area, you really do need to have somebody at a sounding board that has some background and knowledge about what you're doing. So yes, I think I'll continue to mentor for a while, but I'll eventually train my replacement because there are so many young physical therapists interested in pelvic health that are always asking me about what I do and wanting to potentially do the type of work that I do. So I know that there will be people that will come after me someday. I will not be the one and only. I know that for sure.
So is there, I guess in closing, is there anything else that you want to make sure that our audience understands about the difficulties or the challenges of trying to launch a new PT program in a low resource country?
Oh, the challenges are many, and it's having good internet connection is a blessing that doesn't always happen every time. So that in and of itself, the patience that's required to just go, okay, that didn't work, regroup, we'll try again next week. That's a reality. And then there's I have to pause and say, this is from my perspective, and I need you to share it from your perspective. Does that make sense, or is it not going to fit what your culture or the environment or what you're seeing in front of you? The wording, I really am so fearful of not providing information that's not culturally competent for them. And so that's where the mentorship really helps, because I've always told them that they have to mentor me. They know more about Uganda than I do. And so I'm going to need help translating what I know into helping them translate it for themselves. So that translation of knowledge piece, it has to be very delicately done, just so that the women are the ones that benefit.
Mm-hmm. And in terms of COVID, the pandemic's impact on their ability to provide PT services. I know that sometimes some of our, like for example, in Danja, they did group classes for physical therapy, but since they were launching, was it actually more important for them to start with very individualized one-on-one stuff? So are they eventually going to get to group classes, do you think, or is it more going to stay one-on-one or a mixture of both?
You know, I would really love that they can get group classes started. There's some pieces that are just building endurance or building coordination or strength that can be done in a group class. And the group class has a secondary benefit of developing community amongst the women, so that they have someone that who identifies with them, that they're going through similar pieces. So there's many benefits to that. I do believe that there'll always be a little bit of a need of individualized care, so that they would have to probably have a combination of group activities and then individualized assessments, so that the women, because each person as they come in has different degrees of weakness or pain. And so you have to individualize treatment for them in some regards. And so that model, I think, based on models that I've observed in Ethiopia and in Danja, in Niger, work really, really well, because having that community really helps the women feel supported.
This question, you've also worked with physical therapists in Ethiopia at Ader Hospital, which is a referral hospital and treats. So how is it working with the team there versus working the team in Terrewode, where it's a fistula hospital?
I would say that it was so much easier to talk about pelvic health and have it be accepted as a norm that PTs are going to do in the fistula hospital. When you come into a referral hospital in a major medical center, the physical therapists have to be almost convinced that the women need the care. And so you have to kind of keep working. It's like an uphill climb because they didn't learn about women's health, pelvic health in their entry level. And they know physical therapy from what they learned, but they do not, that cross on women. Women are underserved, women aren't getting what they need. Physical therapists really need to help with this marginalization of them simply because they're women and they're not getting the care. And so that piece has been a bit of an uphill battle. Just getting women interested in doing pelvic health, because women prefer women providers, right? I mean, these are conservative cultures, so they just prefer women providers. And convincing the management that they should promote their women physical therapists so that they can get their master's programs. The other piece is that the education in Ethiopia isn't as evolved as fast. It hasn't moved as fast as is in Uganda. So the baseline education that comes out the door for your bachelor's education is it's a more established education program for physical therapy. And so the educators in Ethiopia are younger, have less experience, less kind of broad-based knowledge about the profession. And so that professional growth and development has had to occur. So that's why it's taking so much longer. Getting the support to have a specialty in Ethiopia has been a very large uphill battle. When you walk into a fistula hospital, they all go, here comes the PT and she's going to help us with these problems. Yay! So the buy-in is already there.
I think I've exhausted all of my questions on my list, but is there anything else that you want to share with us about physical therapy and its importance for women with childbirth injuries?
No, I'd just like to say that it took me by surprise how the passion that I grew with this, because of how grateful that all individuals that I work with, we get started and they are just so surprised at what physical therapy can do. And so it's simple can be so profound. So doing simple things can really make a huge difference in the quality of the life of the women. And it's just been a blessing to be able to do this work.
Well, thank you so much for joining us today. It was terrific hearing your perspective and hearing what it's like to really start a new program like this. It's really important.
Thank you. I really, again, as I said, it's my honor to be here.
Well, that concludes our webinar for today. I want to thank everyone for joining us. We hope you enjoyed the program and meeting Dr. Spitznagle and hearing about the new programming going on in Uganda. We will be posting a recording of this webinar on our site, so you can feel free to share it. And I want to thank you once again for joining us.